I do want to introduce Dr. Fadi Mahmoud. Dr. Fadi Mahmoud is a medical oncologist extraordinaire here at our cancer center. He takes care of so many of our patients, and I'd like to just thank him for being my partner in crime and want to introduce him for coming up.
Thank you. Thank you for the organizers. Thank you for AIM at Melanoma for giving me the opportunity to talk to you today about a really exciting topic, a neoadjuvant treatment for melanoma. Hopefully we can spread the message out. So before I get started, I need to have some definitions, and I think Dr. Gimbel really defined the clinically positive disease well. When we are talking about clinically positive disease, we're talking about somebody presenting with a lump. It could be a lump in one of the lymph node areas. It could be somebody had a melanoma that was removed and having in-transit disease, or it could be something picked up on the scan. So if we can look here at the PET-CT scan, we can see this is one of our patients who had a chest wall lesion. In addition to that, he had a positive lymph node in the axillary area, as you can see on the PET-CT scan. So it's a disease that's picked up either on a physical exam, or patients present with a lump, or pick up on imaging. And how often we see that? That represents about 15% of people with stage 3 melanoma. So what do we do for these people? What we do now, the standard of care is to do a wide local excision of the melanoma and do a completion lymph node dissection followed by adjuvant treatment. And the rationale for adjuvant treatment is the surgeon take the tumor out, as you can see here. There probably is few melanoma cells left. I mean, how can we know? I mean, we don't know. I mean, there's definitely high risk. These melanomas are high risk for recurrence, even if you take it by surgery. So the whole point of giving adjuvant treatment or treatment after surgery is to decrease the risk and the chance of the melanoma coming back. And as you can see here, when there is a little melanoma cells left, you don't expect that you're going to have a lot of activation of the immune system. I mean, yeah, you can have activation of few different T cells, and these few different T cells will go and patrol the body and try to protect you and kill the seeds, what we call them the seeds, if they are somewhere in the body. And that has been the standard of care. And we have a very good clinical trials, phase 3 clinical trials, whether we're talking about pembrolizumab, we're talking about nivolumab, or we're talking about targeted therapy for people whose melanoma harbors the BRAF-V600E mutation. All these people will get a 1-year treatment. And across the boards, these treatments decrease the risk of melanoma by approximately 50%. So they are a very effective treatment. Well, we started shifting our thinking a little bit. How about if we take few cycles of immunotherapy and just give it before we send the patient to surgery? What happened? One of my patients who underwent this treatment, and I really, what she told me, I tried to explain to her in scientific terms what's meaning of neoadjuvant immunotherapy. And she told me, well, if there's no tumor, the immune system is not going to see it. And that's true. I mean, when you have the tumor is in place, then you would expect to have activation of many different T cells, many different immune cells. Even if the surgeon removed it, as you can see here, even if the surgeon removed the tumor, you are still left with a lot of, activated, you have a robust immune response because you gave the immune system immunotherapy just before the tumor was removed. Then the patient comes to me and said to me, he asked me the question, did it work? Well, in adjuvant treatment, is it going to work? I don't know if it's going to work if I'm going to give you adjuvant treatment. I know there's data. I know it helps. And I hope that you are going to benefit from it. But now, did it work? Because we're having a pathology report. We can talk about complete response. Is it near complete response? Is it partial response? Is it no response? So we can tailor the treatment and helps us design the treatment after the surgery is done. What other benefits? Maybe it makes the tumor smaller and it can help the surgeon, remove the tumor, and it makes the surgery easier. Again, I just mentioned, evaluate the pathologic response. I have many times, Dr. Gimbel, he just turn the chair, give me the pathology complete response. Turn the chair, give me. It's just we're seeing complete responses. Again and again and again. This is really exciting. That helps me. That's exciting for me. When I tell my patient, we got it. And then I show them the pathology report. They say, wow, that's wonderful. So and also it helps the scientists to look at the tumor microenvironment to help advance the science. How can we evaluate response to neoadjuvant treatment? Well, there's two ways. We do imaging before we send the people to surgery, and that's the same patient I was talking about. Had a primary tumor here, he had a lump here in the lymph node. And as we can see here, we're going to talk about his case, after neoadjuvant immunotherapy, 2 cycles of immunotherapy. He got a complete radiologic response, gone. We can evaluate it by pathology. As you can see here, 0 viable tumor. The pathologist can tell 0 viable tumor. That's a complete response. Less than 10% melanoma cells, near complete response. And you may hear the term major pathologic response, which means both of them, the complete response and near complete response. Partial response, 11 to 50% residual, or no response. You've got more than 50% residual melanoma cells in the specimen. And I'm going to talk to you about the clinical trials that showed that any person who had any type of response, if we give neoadjuvant immunotherapy, the outcomes are great. So this is the study from Europe, Opaci Neo trial. I don't want to confuse you by the design, but basically these are people who had the measurable disease. We defined what measurable disease. We're not talking about people who had a sentinel lymph node biopsy. We're talking about people who had a measurable melanoma. And they were randomized to one of 3 arms. First arm, ipi-nivo, ipilimumab 3 milligram per kilogram, nivolumab 1 milligram per kilogram. That's the standard regimen we give for people with stage 4 melanoma. In the second arm, they said, well, let's decrease the dose of ipi. We know ipilimumab, they have a lot of side effect, people who had used ipilimumab. So let's decrease the dose of ipi and increase the dose of nivo. And we gave here 2 cycles, or they get 2 cycles of ipi followed by 2 cycles of nivo. The arm A was the winner, or the most preferable regimen to use before surgery is done. Why? Because the responses are great. I mean, 77% compared to the first arm, which is 80%, but the side effects slashed by half, 20%, a grade 3 and 4 toxicity. So that's really great. And that's what they used in another trial, an extended trial that I'm going to be discussed next. It's called the Prado trial, with an extension for this cohort. And we'll discuss it in a couple of slides. Look at the event, 2-year event or recurrence-free survival. So that means the people who did not have any melanoma at 2 years, 83.6%. And if we look at the subgroup analysis, people who responded, any response, near complete or even a partial response, 96.9%. How about, adjuvant treatment? All the clinical trial of adjuvant treatment, what's the recurrence-free survival? We just said about 50 to 60%. We're raising the bar here. When we're giving immunotherapy before surgery, we're having 96.9%. That's really exciting. This is the Prado trial, the same group in Europe. They have adopted the arm B regimen, what I call IPI1, Nivo 3, and they enrolled people with measurable disease. And what they did, and this is part of a clinical trial, this is not the standard of care. Again, in the United States, still we do completion lymph node dissection followed by the treatment, adjuvant treatment. But when we want to do immunotherapy, we give a couple of cycles before the surgery. In this trial, they're just taking one lymph node. They call it the target lymph node. They remove it, send it to the pathologist, and if the pathology came as complete response or near complete response, they're not doing surgery. They're not doing even immunotherapy, just observation. If there is a partial response, they do surgery alone, no immunotherapy. And if there is no response, these people, they do a completion lymph node dissection in addition to the full year of treatment, which is the standard of care, either immunotherapy or target therapy based on the BRAF mutation, if the melanoma has a BRAF mutation. Again, this is not the standard of care, it's part of the trial. But look at the results. Again, 2-year event or relapse-free survival, 85%. And when we look at subgroup analysis, people who had a major pathologic response defined as no melanoma, zero melanoma, or less than 10% melanoma left in the tumor, we have a 2-year event-free survival or relapse-free survival, 93%. But look at the group who developed partial response. I mean, you would imagine that people who, how come people who did not respond did better than people who had a partial response? Well, I mean, we have to this results raise the question that we perhaps need to give immunotherapy for people who had a partial response. I mean, they should. And in this trial, they did not get immunotherapy. That's the reason it's an evolving field. Whenever we have a clinical trial in our institution for neoadjuvant treatment, we have to enroll people in this clinical trial because we need to get the answers for a really important question like this question. But if there is no clinical trial available, we are doing, and I'll tell you about the regimen and what we are doing in terms of neoadjuvant treatment. So this is, we go back to our patient. He presented to us, I believe, in 2020, and he had a chest wall lesion. And he came in and with a big lump. And the PET CT scan is showing that. So we talked to him about neoadjuvant treatment. We did not have a clinical trial open in our site. We really believe in this. And we, by analyzing the results and the data coming from Europe and coming from the United States, it was just a natural transition for people like physicians like myself. When we care for people with melanoma, we have seen it working in stage 4 disease, eliminating the disease. You've got brain mets, you give immunotherapy, it wipes it out. We see it working in adjuvant treatment. It was very natural to adopt this in our clinical practice. So we talked about 2 cycles of Ipi/Nivo. We were planning to give him the 1 milligram per kilogram, like the same trial done in Europe, 2 cycles every 3 weeks, and then do the surgery, and then meet him after the surgery. Well, he developed diarrhea due to colitis, and we had to treat him with prednisone. Thankfully, the diarrhea was not bad and actually resolved by the time he came to see me for cycle 2. In cycle 2, I talked to him. I said, well, typically we give Ipi/Nivo, but I'm worried about your colitis, your diarrhea. How about we go with just one drug, was Nivo? And we gave him just 1 dose of nivolumab. And then he developed colitis again. And I said, that's it. Let's, we're going to treat you with prednisone. We're going to take care of the colitis. We're going to send you to Dr. Gimbel for surgery. We did a scan for him, complete response. So complete radiologic response. And he underwent the standard of care in the United States, again, completion lymph node dissection. And there's 0 melanoma. This is a complete pathologic response. And that's his PET CT scan in May of 2023. He continued to do great. I think we're seeing him every 6 months. He's looking to be seen every year. I have no doubt that we got this melanoma, and I think even going to a year would be fine. But it's really, really exciting. Dr. Amaria at MD Anderson in Houston did a small clinical trial there. They have published their experience with Opdualag, and Opdualag is a combination of nivolumab and relatlimab. And the nice thing about this combination or Opdualag therapy is the side effects. I mean, the grade 3 and 4 toxicity in stage 4, when we give it to people in stage 4, is only 17%. When we think about the combination of ipilimumab and nivolumab, it's really having a higher toxicity than Opdualag. So it's a really nice treatment for people with stage 4. So she applied it in the neoadjuvant setting, and she is using it. She used it in 30 people with, again, clinically positive disease, gave 2 cycles of this Opdualag. It's given once a month. So within 4 weeks, you get 2 cycles, and then you go to surgery. And then she followed them after surgery and gave them the same treatment to complete a full year of adjuvant therapy. And again, the responses, if we look at the this figure here, the pie. We've got most of the people, the complete response is in 57%, near complete response, pathologic complete response in 7%. Altogether, including pathologic partial response, is about 70% of the people have a pathologic, any pathologic response. And if we can look at the survivor curves right down here, we see again that most of the people who got neoadjuvant treatment at year 1, actually 100% recurrence-free survival. And at year 2, it's 92%, while people who did not respond at year 1, it was 88%, and at year 2, it was 55%. So again, I mean, neoadjuvant treatment is really, really exciting. I'm going to talk here about the S1801 clinical trial. So if we look at arm B, or the second arm, this is the standard of care in the United States. To do surgery, do completion lymph node dissection, and take a year of immunotherapy, whether it's Opdivo or Keytruda. In this trial, they gave Keytruda. Then the scientists in this trial, I said, how about we get just the 3 cycles of Keytruda and we give it before? Just the 3 cycles. It's genius. This is confirmed why, the rationale behind doing neoadjuvant immunotherapy. Look at these curves. Just by getting 3 cycles of Keytruda and giving it before you do the surgery, you get a better 2-year event-free survival for people who got neoadjuvant Keytruda versus the people who got adjuvant Keytruda alone. That study is absolutely genius, and it confirmed to us that neoadjuvant therapy is the way to go in the future. At this point, it's important, the first point. A lot of people are anxious when we meet them. I want this tumor out. I want to go to surgery right now. Well, you can go to surgery right now. I mean, as a matter of fact, if we look at the people who enrolled on adjuvant treatment, who got the surgery right now, and they are ready to go to adjuvant treatment and receive, if you look at those people enrolled in the clinical trial, about 15 to 20% were excluded from the trial. And you know why? They have stage 4 disease. This is why, if you want to get the surgery right now. So yes, here in neoadjuvant treatment, we have about 5% of people may end up having metastatic disease, but we spared them unnecessary surgery. The biology of the tumor is off. I mean, if you're going to have metastatic disease within 6 weeks from diagnosis, you better not go through the surgery. But it's 6.5% in this trial. Look at the people who went through surgery, and they're having 11% metastatic disease. So again, neoadjuvant treatment, the message is neoadjuvant treatment is the way to go in the future. So conclusion, neoadjuvant therapy allow for rapid assessment of pathologic response and radiographic response. Any pathologic response is good if we give immunotherapy. Now, in targeted therapy, it's different. If people who got targeted therapy for surgery, you got to have a complete pathologic response to have a good outcome. Not, a partial response, near partial response is not going to work. That's the reason immunotherapy is the way, not targeted therapy is the way. Should we give Keytruda alone, single agent or double agent? I think it's dual agent immunotherapy. And the data tells us when you give dual agent, you have a better event and recurrence-free survival, though they were not compared to head-to-head. And hopefully stage 3 trials in the future, they will give us the answer. So the available data from phase 2 studies challenge the current paradigm of surgery first, then followed by adjuvant treatment for people with clinically positive melanoma. And thank you very much for listening.